Good morning or good afternoon, everybody, depending on where you are in the country. Welcome to our webinar on supporting harm reduction in COVID-19 shelter and self-isolation. I'm pleased to welcome our speaker, Dr. Christy Sutherland, who I will introduce in a moment. First of all, just want to quickly go over our agenda for this webinar. We'll have a quick introduction, followed by a presentation by Dr. Sutherland, and we will have a question and answer period. The question and answer, just to let you know, a bit of housekeeping, you'll find a question and answer tab on your control panel, just says Q&A. Please use that tab to ask questions. We have over 975 people registered for this webinar, so it would be a bit difficult to do questions any other way. We also have a chat function. You can share information, use that chat function to share information with your colleagues and share information or ask if you have any issues on technology or whatnot, you want to just ping one of the presenters. The chat function has been very useful in our other webinars. A lot of the questions people will have or information that comes up in these webinars, there's people around the country, around North America, who are on this call who will have some good information. Please feel free to share information, answer questions, provide comments in the chat function. We are going to be posting a webinar, a recording of this webinar on the Canadian Network for the Health and Housing of People Experiencing Homelessness, cnh3.ca/resources. We are continuously updating that library of resources with information to help communities respond to COVID-19 in partnership with CNH3. Also, please feel free and do please send us your samples and good program ideas and policies, procedures. All of those things are super helpful to your peers in helping them get ready for COVID-19. I know everybody is scrambling, so the sooner, the more resources we can put up, the faster other communities can respond. With that, I'm going to introduce our colleague, Dr. Christy Sutherland. Now, Dr. Sutherland is a family doctor and diplomat, I haven't heard that title, for the American Board of Addiction Medicine and works in Vancouver's downtown east side. You see her bio here, but she's the medical director of the Portland Hotel Society, where she leads a team of physicians and nurses who are embedded in low barrier harm reduction projects. Certainly has a ton of experience doing this important work. I am going to stop sharing my screen and pass it over to Dr. Sutherland, who will get started, and I'm going to disappear into the background. Over to you, Dr. Sutherland. Thank you very much for joining us.
Thank you so much. Yeah, I'm delighted. And I'm delighted that so many people came. Okay, I'm going to attempt to share my screen. So let's see how this goes. Can you see my PowerPoint?
Yeah, it's up.
Do I need to do it in presentation mode?
Do it just like, yeah, you've got it there. That's perfect.
Okay, great. So this presentation is aimed at prescribers, and it's about our new substance use and safe supply guidance that has come out in BC. But I think it has lots of applications for everyone to know about, so that you can know that prescribing has shifted in British Columbia, and I think will shift across Canada because of COVID and trying to keep people safe. In writing these, they don't quite meet the criteria for the guideline in terms of research and process, but we call them guidance, so it's interim guidance. It is so hard, and I found the same at the Portland Hotel Society, where we have people who are homeless, we have people who are in shelter, we have people who are in our low barrier housing projects, and so it's hard to write a policy that applies to all of those different contexts. So we're just trying to provide a framework for what you can choose from to what applies in your site. So I'm on right now the unceded territory of the Coast Salish people, Musqueam and Tsleil-Waututh nations, and I am grateful to be here as a settler in Canada. For my conflicts of interest, I receive a salary from the BC Centre on Substance Use as their education lead, and then this presentation was prepared with myself and my colleagues at the BCCSU. And also my other big bias is that I work in the downtown east side, and so I get paid by the PHS to be their medical director. And then I've just started sort of declaring this as a bias before I give presentations, because it really has colored like who I am as a person, I think, and how I practice medicine. And so sometimes when I'm speaking to colleagues in rural settings and things like that, they're like, get out of here, Christy, like what you're saying is nonsense. And I'll be like, oh, well, different contexts, different things, but this is, it certainly colored how I practice medicine. So I just like to declare that so you guys know. I'm not pretending that I don't work in the downtown east side. So we can talk about our objectives, the background for this work, and then overview of this safe supply guidance document for physicians and nurse practitioners, so any prescriber, and then talking about opiate agonist treatment and COVID. So let me see if I can move my little box here so I can read my own slides. Oh yeah, okay, perfect. Okay, so we have 2 public health emergencies, as we know. So the opioid overdose crisis, I'm sorry, I can't move my own photo so that I can see my own slides. Yeah, I mean, it's just horrific for this community of people who use drugs, and then to have COVID on top of it is, I mean, just a tragedy. So we want to be able to best support this population based on the evidence that we have and individual patient needs and the context of their life. So that's why I love being a family doctor, because I follow people longitudinally, and that whenever we make plans together, I talk with them about like, what is going on in your life right now? What are your goals, and what is reasonable in terms of a plan? And then changing that plan in terms of COVID. Okay. So COVID is a pandemic, and that social distancing measures are reduced hours of operation of the pharmacy, clinical services may be changed to telemedicine or reduced hours, and it also may mean disruption in drug supply for people who use drugs. We sort of mulled over this in BC because most fentanyl comes in the mail, and so I was wondering why closing the border would disrupt drug supply. And one of my colleagues at the CDC told me that actually a lot of the substances they need to process the fentanyl and process drugs comes from the States. So even though crystal meth might be made in my bathtub here in my apartment, a lot of the products that I need to cook the crystal meth come from the US. And so with that border closure, it is going to disrupt our drug supply, even though so many drugs come in the mail or are manufactured locally. And so we need to think about this as care providers for this patient population, that people are at risk of withdrawal and at risk of death, and at risk of exposure to COVID through trying to seek illicit drugs in order to avoid withdrawal, avoid seizure. So let's talk about these safe supply guidelines. So this was a document, like, I mean, I'll never see it again in my career, I don't think, to have something go from a blank page to a provincial guidance document that's been signed off by the Ministry of Health and all of our colleges. Like, it's just incredible. And I'm so grateful to all of the hard work that was done by people across the province. And when we thought about, okay, how do we manage the different substances? And so there can be a different strategy for each substance, for each person. And we divided it into opioids, stimulants, illicit benzodiazepines, tobacco, and alcohol as things that need to be addressed in order to help people stay isolated. Because I don't think that social distancing or isolation should be like a purview of people who are wealthy, like that anyone should be able to access safety. And that really is the philosophy, I think, behind harm reduction, where I think about my own life and the things that I have in my life that I enjoy. And then I think, oh, probably people who use drugs would also enjoy that. And how can we set that up for them? And that safety is a big one, like that I really enjoy the luxury of safety. And it's something I reflect on in my life a lot. And that how can we help people who use drugs also be safe? We put a caveat in here that this is not substance use treatment, but I think for me, the definition of treatment is quite fluid. You know, it's sort of living your best life, it's quality of life. And over the years, I've grown less and less bothered by whether people use drugs or not, and more I'm worried about their goals and their safety and things like HIV risk and things and criminalization, that I don't want my patients to be criminalized. So I think that if people get better on something, then you can call it treatment, but we put that as a caveat here. So for eligibility, we put, oh, I feel like I'm missing a slide. Oh no, okay. This is the first time I'm giving this presentation, so you have to forgive any bumps along the road. And then as well, I'll see what questions people have and feedback, and then I can incorporate it for the next time I give it. So basically, eligibility is anyone who uses drugs, because everyone is at risk of a COVID infection, right? And so this is a population we want to protect. Like if you're already smoking crack, you might already have lung injury or underlying COPD. Often my patients are very frail, and so I'm quite worried about them getting COVID. So I really want to protect them, and that we are worried that the illicit market is a place where COVID will be transmitted. It's hard to practice social distancing with your drug dealer. I learned recently, because we were speaking with drug dealers, about we put hand sanitizer in their rooms, that kind of thing, to help them sort of have a COVID protection moment for the people they're selling drugs to, and that they were reluctant to put drugs in baggies because that might increase their charges if the police were to arrest them, like for trafficking. So that there's a lot of like a confluence of, you know, it's an intersection of vulnerabilities, I think, for people, and that the criminalization of people is really brought up, like even in more acute light of how harmful that can be to our population. So we want to support people to self-isolate. And so this guideline is for people who use drugs. You have to be a drug user to be getting prescription drugs, and that at risk of withdrawal, overdose, craving, or other harms related to substance use. So we made it quite broad. And that pregnancy and youth are not an exclusion for this guideline. We did note them as a special population that deserves special consideration. So you really want to rate the risk and benefit for each individual case. And I would always phone a friend. If I have a challenging case, I'd like to phone up a friend and just chat it through, document that I've talked about it, and then you know, discuss with the patient and truly feel that the plan that you have is less risk than no plan. So in developing these guidelines, there's really no literature to support these guidelines right now directly. You know, that this has never been done before, and it is being evaluated now, but we can't look to the literature really to guide us on how to run this safe supply program for our wide population. But it is actually not a far stretch, I don't think, from what we are already doing. So I've been doing IOT in my clinic since 2016, and that it has been, you know, standard of care in Europe since the 90s, and has robust literature. There's a Cochrane review to show that it decreases illicit drug use, increased attention to care, decreases crime, decreases public disorder. And then when we look at how much money people spend in the illicit market, it decreases by thousands of dollars. And so we know that IOT helps people exit the illicit drug market and helps them exit risky activities such as sex work. Based on the IOT literature, I created my TIOT program in January 2019. So it's been running for about 14 months. And that's where I'm giving out people dilaudid tablets. And we have 80 people on that program. 60 of them are on tablets and 20 of them are on injectable formulations. And it was different than IOT in that it's all PRN dosing. So it's all as needed. You can come and go as you like. You can miss weeks at a time and just show up again. And then those medications are there for you to inject inside the overdose prevention site. We picked people who were frequent overdosers to start that program. That's our target. And so, and none of them have overdosed. And so we've had no overdoses in our IOT or TIOT program among the hundreds of patients that we've treated for the past almost 4 years. So we have a lot of clinical experience to tell us that giving people opioids who are opiate users protects them. This also really reminds me of managed alcohol programs. So we run 2 managed alcohol programs at the PHS, and they're wonderful managed alcohol programs, often shelter-based across Canada. And that we know that they improve quality of life for people. They decrease violence, they decrease presentations to the emergency room, and they decrease interactions with police, and they increase quality of life. And the thing about managed alcohol programs that's similar to my IOT and TIOT programs is that people don't want the maximum dose, I find. I find for my patients with opiate use disorder, I'm often trying to still coax them to go up on the dose. I say, like, if I was an opiate user, I'd be on the maximum dose of everything. And my patients sort of laugh at me and they'll be like, oh, you'd be a drug seeker, would you? And I'd be like, yes, I absolutely would. I would be seeking everything and I'd be on the top dose. Like, I just want you to be comfortable. And if I was an opiate user, I would want to be comfortable. So let's go up on your dose. And I have found that experience to be quite common. And you think, I think that when I was originally creating that program and talking with my colleagues and funders and our stakeholders, the worry was that every person would want to be on the maximum dose forever, but that has not at all been the clinical experience. That it is very similar to methadone, where you're saying, like, let's go up on your dose, let's go up on your dose, because people are worried about the long-term coming off. So they're trying to set themselves up to be on no drugs. And I always say, you're going to be comfortable in the middle, and then you can do a taper in a year or once the crisis is over. And so I think the IOT, TIOT, and managed alcohol programs can really inform us for this new safe supply program, that we can be reassured that people are quite insightful and thoughtful about their own health and their needs. Nicotine replacement is a very common intervention. You know, you can pick it up in the pharmacy here in BC. We know that it saves lives in terms of smoking cessation. We know it's very effective, and that it's very palatable, that it makes sense that if you're a smoker and you go on the nicotine patch and you stop smoking, your health is better. So I think that we can look at these safe supply guidelines as a parallel to that. This is like nicotine replacement treatment. We also have some unpublished literature in Vancouver about people buying illicit hydromorphone, and that their urine drug testing over time was lower for fentanyl exposure. So that was another thing that sort of informed these guidelines. So I think that although there's no research, these will be research, but there's no research that really guided how we wrote these. There's where you can extrapolate from clinical knowledge and research published in sort of parallel areas. So we have a lot to offer patients. For opioids, we are trying to increase the dose and do carries as needed. So any of my patients who feel that they have a safe place to store their medication, like housing or a lockbox, or you know, whatever their circumstances, as we speak and talk about safety with them, I've put people on weekly dispense or every 2 weeks dispense to prevent them having to go to the pharmacy. Been prescribing oral dilaudid that they can inject or swallow or muscle or snort at home as they like. And then MS-LON as well is another option for people. Some people prefer that in terms of how they like to cook it, to inject. For benzodiazepines, it's not really that different from what we were doing before. In terms of illicit benzo use, there's not a lot of literature to guide us on how to convert someone from street benzo use to prescribed benzo use in terms of what dose to use. You're really shooting in the dark, because although they may know what their drug dealer tells them they're taking, that often is not actually the pill, and it's quite contaminated, and so you don't know the dose, and they don't know the dose of those tablets that they're taking, and they don't even know many times the substance. I think Xanax has high street value because it's, you know, it's a familiar name, but much of the time that what they're buying is not Xanax. And then if you go to the conversion tables for Xanax to Valium, I mean, you end up with massive doses that would sort of stop your heart. You know, previous to COVID, what I might do in that situation is ask my colleagues at Vancouver Detox to admit that person to an inpatient stay for a few days to figure out their true benzo need. But we can't do that now in this context. So it is a bit of a shot in the dark, but you can start low and follow up with them frequently, hopefully over the phone, and then titrate to as they need, and then talk with them about safety and sedation. For stimulants, you can prescribe dexedrine or methylphenidate. This one, I think, is the biggest leap in terms of going from research that has been done to integrating this into practice. Before this, I had not been prescribing stimulants for substance use disorder because the literature really was not compelling enough. There's one trial that showed decreased stimulant use that was quite successful, but it was done in a heroin-assisted treatment clinic, I think in Switzerland. And so it was a very specific context. However, when we look at the literature about stimulant prescribing for substance use disorder, it is there's some flaws, or some limitations, I guess. I shouldn't say flaws. It's just getting started. You know what I mean? It's not their fault yet. They haven't answered the question. I appreciate my research colleagues, but that the dosing is often low because it's based on ADHD dosing, and we don't want to kill people with our dosing of drugs in clinical trials, which is very reasonable. You want to use a safe dose. But if someone's like injecting an 8-ball of crystal meth a day and we give them ADHD dosing of stimulants, like, you're probably not going to meet their need. As well, the limitation for so many trials in addiction medicine is that it's 12 weeks long. So many of the trials are 12 weeks, and then the outcomes they look at are urine drug testing and retention to care. So they miss the outcome of quality of life, which I think is really important, and that in addiction research, we're getting better at that. One of my favorite trials that I've ever read, we just came out with our new alcohol use disorder guidelines, and I was reading the topiramate literature, and one of the outcomes was housework. That, are you doing more work around the house? And I was like, oh my gosh, that's such an important outcome, because it really makes a difference for the quality of your relationships and the quality of your life. And to think that if you start topiramate and you have increased amount of housework, then, oh my gosh, that's a really good outcome, even if your drinking doesn't change that much. And I was sort of thinking, I don't do any housework in my life. Like, I do zero. My husband does it all. And I was like, oh, maybe he would like it if I took some topiramate. But you can select short acting or long acting for this dexedrine or Ritalin, and then just chat with the patient about what they would prefer. There is subsignal. I have to exit my screen here because I wrote myself little notes. That dexedrine might be better for cocaine use with regard to sustained abstinence, and that's by the Cochrane Review. And then methylphenidate might be better for crystal meth use, but this is all very preliminary and not enough really to guide our practice outside the context of this COVID emergency. For alcohol and nicotine, we have set up in our housing and shelters for supporting people with isolation that we will deliver cigarettes and alcohol to them, because you really don't want them leaving to purchase these things, especially most tobacco in the downtown east side is purchased on the street corner from like, I don't know where they get them, but it's not the regular factory. It's like off the back of the truck kind of cigarettes. And that we don't want people seizing alone in their room. So you really want to support them with their needs for staying at home. And coffee as well is another thing that we're delivering, where coffee is a really common reason for people to need to leave. So we wanted to get this word out to the community, because this is a provincial-wide guidance now for all prescribers in BC, that we want to keep our patients safe, so that for any drug user, we want to encourage them to go see their physician. And we set up a line for physicians to call for advice about how to prescribe in this circumstance. It's much easier to do this with a patient that you already know, because you have their urine drug tests on your record, you have a nice relationship with them, and you can say, like, you know, tell me what you need. It's much more challenging when it's a new patient. Although, I mean, things are really, I mean, I'm always surprised and I'm always learning that we do new intakes for patients. And you think if you said, okay, tell me what you need, the sky's the limit. Well, I had one patient say ice cream, and I was like, oh, okay, but well, I'm asking you about drugs. Like, what drugs can I give you? And he was like, oh, I just really want ice cream. I was like, okay, for sure. I'll talk with your housing provider. We can see about some ice cream, but what drugs do you need? And it was like, you know, his third answer was about the drugs that I was describing, his first two answers for ice cream. So, I mean, it's quite interesting. And then we had another intake where the person just wanted Tylenol 3s. And so if you think, if you're seeing a physician and they're like, oh, I'll start you on 14 dilly 8s a day, and you're like, oh, no, thanks, and Tylenol 3s are just what I need. Like, that people are quite honest and forthcoming about their needs, I think. So I think, you know, I always think about good faith, that often people who use drugs have been unfortunately mislabeled as entering into clinical relationships in bad faith and being called drug seekers, or they've been dismissed, their pain has been dismissed, or they're the missed heart attack because they, you know, they're told that their symptoms are probably due to their crystal meth. Like, but that people who use drugs come to medicine in good faith, and we need to meet that good faith and respect it and support them in their clinical choices. And that has really served me well in my clinical practice, because then your patients tell you the truth, and then you have nice discussions, and then you can follow them over time and change your clinical plan. So for the prescribing, we really want people to stay with their own prescriber in BC and have that prescriber implement this plan that's specific to them. If they have no prescriber, we have a system to connect them with our Rapid Access Addiction Clinic, who will do a telehealth visit with support from our outreach team. I mean, it's incredible. We got all of these medications covered by PharmaCare through Plan G, so every patient just needs to sign a form and we fax it off, and within 24 to 48 hours, all of these medications will be covered for them. And then they pitched 23 days to track on PharmaNet, that it will be easy to flag these prescriptions for research later. And also, you want a nice duration. Like, you don't want to be doing short durations of your prescriptions. I'm actually doing 56 days in my clinic, because you don't want people to run out and then to think about that administrative burden of refilling prescriptions. As well, Health Canada has changed the Controlled Drugs and Substances Act in response to COVID. So pharmacists can extend prescriptions. Pharmacists can transfer prescriptions to other pharmacists, which is new. Pharmacists can do verbal orders, which has been like such a luxury. I can't tell you, as an opiate agonist treatment provider, you know, the evening somersaults I have to do to fax something sometimes, or like I'll be calling around to pharmacies, like trying to, you know, charm them into filling an OAT prescription for one of my patients. So it's just wonderful now that we can do verbals for that. And I think very reasonable. People, I don't think, are fraudulently going to be phoning in methadone prescriptions for themselves. And then now there's increased sort of discretion for the pharmacist to do deliveries, because we really want to keep people out of the pharmacy, out of these crowded lineups, so that the pharmacist can just bring it to their home, drop it at the door. We have a protocol at the PHS for like a distance drop off, where they knock and they can talk with the person through the door. They drop the package at the door and then walk away 2 meters, and they can see the person pick it up. So yeah, we want to be prepared for each of our patients that they don't miss doses of their opiate agonist treatment. And then, so you want to plan with them about phoning for follow-ups. I've switched all my prescriptions to 2-month-long prescriptions. And then I've offered people take-home dosing. So you want to document well. That's always the rule in medicine. We wrote, and I'm happy to share them, PHS-specific COVID policies. And we created templates in our EMR so that if you have someone who you're seeing for safe supply intake, you can just pull up the template and then fill in all of the parameters. And then it says, see PHS COVID policy and these guidelines so that you know, years from now when our charts are being audited, or, you know, if there's a complaint to a college looking at it, that we have nice, you don't have to write all of the reasoning in each clinical chart note, you can just have it in your policy for your organization. Yeah, and so for longer carries, it's always a balance of risk because you don't want people burning through their drugs and maybe overdosing. So let's say I have someone who had been on daily dispense before because they were ongoing cocaine use or crystal meth use, so they didn't meet the criteria for take-home dosing, and now I'm giving them take-home dosing because of COVID. You want to have a nice chat with them and say, like, are you safe? You know, do you think that you're just going to use all these drugs on the first day? Maybe you need Monday, Wednesday, Friday delivery, or maybe like you're going to have it in a lockbox that your friend keeps. So, you know, every situation is so unique. It's hard to write overarching principles, but I guess the overarching principle is safety and asking the patient, like, what do you need? What is your circumstance? How can you be safe? Because the first day that I started this, I thought, oh my gosh, my patients have been wanting take-home dosing for years, and I've been following the guidelines and not giving it to them. So now take-home dosing for all, I thought it was going to be just bliss at the clinic. And I only had one person actually on that first day of like the 50 people I saw who wanted take-home dosing. For a lot of people, they get kickbacks from the pharmacy. So it's a source of income to have on daily dispense medications. And for others, they were like, oh, my pharmacist, I've known him for 20 years. He's my only contact each day. I want to keep seeing him every day. And so, I mean, that's what's important to them in their balance of risk. For urine drug testing, we've sort of stopped doing that at my clinic, other than a new intake of someone we've never met before if we can't find any urine drug tests from them elsewhere. But really for COVID, like one of our big goals in community is to offload acute. And so thinking about like every test that we order, every CT we order, every consult we order is potentially taking up capacity that could be redeployed to acute for COVID response. So we want to be very judicious in anything that we're ordering. Okay, for Acadian, we used to do sprinkles. People hated it. It would get stuck in their teeth, but it was to prevent diversion. So we stopped sprinkling Cadian because it's just more time at the pharmacy and the pharmacist having to handle the medication more. So people were very happy with that. For pharmacists, we want to make sure that people don't stockpile things. We don't want any shortages. So even for your patients as well, like, you know, you don't want to be writing massive scripts for them to stockpile for a shortage, especially like when we think about palliative care, like we don't want to be causing shortages for our colleagues. Like we don't want a hydroxychloroquine azithromycin situation here with opioids. We want them to be available for the people who need them. And so in BC, our pharmacare colleagues have been in touch with the manufacturers to secure supply chain, to increase production of these drugs. So we have no anticipation of supply chain or shortages on any of these medications, but that's important for clinicians and pharmacists to also be good stewards to that system so that we don't stockpile. Okay, and then more guideline for pharmacists that we want to emphasize delivery and safety for staff. And then we're still considering at the PHS because we do have a medication management system throughout our housing where the workers give out medications, but we haven't been doing opioids in that. So it's something we're considering as capacity changes. You know, it's such an unknown for extrapolating how many COVID cases we're going to get in the downtown side and what the capacity of the outreach teams will be. And so we sort of want to plan for the worst. We have bulletins that we can share across Canada about these changes for opiate agonist treatment prescribing for physicians so that they feel quite secure, because often for physicians, like we've been told for many years, like these are the rules for take-home dosing, these are the rules for urine drug testing, these, you know, that these are the rules for sprinkling, and that they've changed overnight. So people are cautious, I think. So these cases, I've de-identified them, like that you wouldn't be able to figure out who it is based on this, but they are sort of based on sort of cumulative cases that I've sort of merged together. So these are sort of real life, but they're not a real person and not a specific case. But this past week, this is the kind of thing that I've been prescribing. So I have a 70-year-old man, and he's been my patient for many years. He's on 120 methadone that he gets daily witnessed at his pharmacy, and he continues to muscle fentanyl, and he's worried about his risk of COVID. So I had a nice chat with him and I said, what do you want? And he wanted 250 milligrams of mescaline that he was going to muscle every day. And, you know, I was surprised. I was like, you don't want more? Like usually for you know, if I was starting someone on Cadian, I would start them at like 300, even to 400 if he was on 120 of Cadian or of methadone already. So to me, that was like quite a low dose. And he was like, no, that's what I need. If I have that every day, then I won't need to get any fentanyl anymore. And then I also offered to say, do you want to switch your methadone to weekly dispense along with your MS-Alon? And he said, no, he likes to go to his pharmacy every day. So it just is, you know, lovely to have these conversations with people, I think, and make these individual plans, and then your patients will surprise you. So I had another circumstance of a 45-year-old woman who was under my care, who's COVID positive, and she was in isolation at our Housing First project. So we do Housing First at the PHS, where I'm sure you guys know all about Housing First, that it's a human right, and yeah, you just want to keep people indoors. So she was using crystal meth 1 gram per day, Ativan 1 milligram at night, and 3.5 grams of fentanyl per day IV. So quite a large amount of drug use. And then when we talked with her, we wanted to start SROM, so Cadian, which is the once-a-day morphine pill. I don't think this is used in Canada very much outside of BC, but I would encourage clinicians to start prescribing it because it is such a lovely medication to use. There's Cochrane review and then several randomized control trials since that Cochrane review that show it non-inferior to methadone in terms of urine drug testing and retention to care. And it's actually superior to methadone in terms of quality of life, that people say their mood is better on SROM. And I definitely find that in my clinical practice. So we started 300 milligrams a day, which I mean, sometimes can make you pause if you're new to SROM, but to remember that it's a 24-hour release in the capsule, so that actually, you know, I can't do math in my head to divide 300 by 24, but the actual hourly dose is not that big. It's much lower than actually what you would start on someone if you were admitting them to acute. And then we go up by 100 milligrams a day. She wanted 7 tabs of allotted 8 milligrams. So she had the option to go up to 14 tabs. And she was like, no, 7's right for me. Like, I don't know how she decided 7. I was like, are you sure? Like, is that okay? She was like, yeah, 7 is perfect. And then the dexedrine sustained release 20, and then 2 tabs of the 10 milligram methylphenidate extended release or quick release. So also not the top dose. I mean, just lovely, I think, that people, and then I always talk with people, we can adjust this as you go. Like you see how you feel and you call us up and I'll phone in a change in the dose. And then we did the Ativan 1 milligram at night. So for long-term plans, you know, this is something, whenever you start something, you have to think about, okay, what then? Like, that's something we're talking a lot about in BC, about what does this mean for our long-term prescribing and our long-term clinical care for people? It doesn't stress me out that much because I think I have the luxury of having this experience in IOT and TIOT where patients come on and off the programs as they need. They'll say like, oh, you know, I'm done with this for now. I'm moving to Mission. And they'll go to Mission for 6 months and then they come back to the downtown east side and they start drug use again. And they'll say, oh, can I start TIOT again? I'll be like, yeah, great. It's great. So, you know, and I think we have to remember as physicians, you know, one of our weaknesses is our ego, I think. I'm not exempt to that, but that we have a very biased view of drug use, I think, as doctors, where we medicalize it, when really most people who use drugs never present to a doctor about their drug use, and they'll use drugs for a little while and then stop using drugs. It's just a normal part of being a human. It's not a medical condition, I don't think. And so that it's the same with this. We're just prescribing safety for people, and that people will come on and off this program over time. So I'm not really that worried for my own prescribing and my own clinical practice about starting people on something and having them on it forever, because my clinical experience is that people don't take things forever. I mean, people don't take their Lipitor forever. So I don't think they're going to take their dexedrine forever either. And so it really has to do with shared decision-making and that rapport and longitudinal relationship that you have over time, and then nothing abrupt. You know, I always tell patients, like, I'm slow, like I never do anything quickly. It's why I'm not a surgeon. Like that I also mix up my right and left a lot. So I'm definitely, we had to do a little survey about where you could be redeployed in the COVID emergency as a physician. And I was like, nowhere. Like, no one wants me doing anything except just drugs. Like, that's all I'm competent to do. But you know, because I like to talk a lot with my patients and I like to take my time. And so that after COVID is done, any changes that we make should be slow and should be thoughtful and should be with the person alongside. Like, we should do the shared decision-making process. It's not paternalistic. And that as we document over time, you want to talk about functional changes, like improvements. My goodness, like this person's retained their housing, they're on their ARVs, they've exited sex work, they've started volunteering, they've reconnected with their family. Like, we've already had, you know, quite nice, we've been trying to provide people phones who are in isolation, and then they reconnect with their family, and it's so nice. You want to document overdoses. Like, if someone was overdosing frequently and then you start them on this sort of like unique regimen and they stop overdosing, well, it's important information, and their drug use over time. And then we can have different plans for different substances so that like you don't have to taper your benzos and Dilaudid at the same time, at the same pace. You can choose what to do first. For me, when I'm looking at how dangerous each of these substances are, I think that the benzos are the ones that worry me the most. Well, tobacco too, I guess, but for what I prescribe, benzos are increase all-cause mortality. For IV drug users, they increase risk of seroconversion to HIV. If you have HIV, you're more likely to have a detectable viral load if you're a benzo user. But I think for my current benzo practice, I do a year, 18 months to taper my patients off their benzos. And then a lot of times when someone's coming from illicit benzo use and you stabilize them on prescription benzos and you do this slow taper, they don't totally stop their benzo use, but they sort of get a new set point of being like, oh, okay, I used to use 2 grams of Ativan a day, and now I use half a gram of Ativan a day. And I think that that's quite nice. And then sometimes they'll do that for a year, and they'll be like, doc, I think I want to do another taper. And I'm like, oh, okay. So we'll restart them on a prescription and taper them again and see if they get a new set point. But it's all very slow, and it's all long-term, and it all has to do with the patient goals. And then the balance of risk. All right, so I am happy to have any questions.
Awesome. Well, thank you very much, Dr. Sutherland. We have got a list of questions started here. I'll remind everyone, please send in your questions to the question and answer panel. And I'll start with Pamela, who was just asking if you can repeat how the US border affects fentanyl use in Canada.
Yeah, well, we don't really know yet, but we think it's because the adulterants to mix with the fentanyl to make it sellable on the street is imported from the States. So the fentanyl that comes from China in the mail can't just be sold straight, I don't think. This is all speculation, and it's all from my colleagues at the BC CDC, but that there are adulterants and mixtures and like supplies that need to come from the States in order to create the product to sell. But I mean, that's all emerging. Like, we don't really know. I definitely hear from my patients that there's less drugs available on the street, and they are stressed about that. But I think that, time will tell.
Okay, perfect. Sarah is asking, she says, we operate a shelter with an overdose prevention site and harm reduction and have a lot of people at risk. If a resident isn't currently connected to a physician, can a caseworker advocate as to the resident's drug use in order to establish high risk of withdrawal from substances in order to be eligible?
Yeah, so each individual physician will have to decide, because they're the ones with their name on the prescription. But I think there's so many variables. For us, like for Oppenheimer Park, which is one of the homeless tent cities here in Vancouver, we've set up a little Zoom so that the physicians can have meetings with new patients to start them on safe supply. One of the key things that can help is a urine drug test, but you need support from the physician to get the equipment to administer the urine drug test. And then collateral history. So for me, if it's a new patient, but I have ER notes that say that they've overdosed 10 times this past year, my goodness, it makes it a lot easier for me to start prescribing them these sort of outside the lines opioids. So I think that the collateral as a community worker is very powerful. And if you've known someone for a while and they've told you, oh, I'm here to use crystal meth every day for the past year in the OPS where you're working, that is really valuable information for that clinician. So you can help them guide their prescribing. And then you could even offer to attend the appointment or do the phone call if it's a telemedicine call with the person, because sometimes patients are not too forthcoming about their histories. They're nervous, and physicians can be intimidating. And so it's nice to have the case manager there to be like, oh, remember, Tim, how you wanted to bring up about your crystal meth? It is really helpful as a physician.
Terrific. One attendee is asking, any creative ideas for getting alcohol to individuals experiencing homelessness who are quarantined in isolation spaces at a motel being managed by non-clinical staff? Our community does not have a managed alcohol program. Second part of this is asking if the Alliance could ask the federal government to specify in reaching home funding directives that alcohol can be an eligible expenditure with prescription. That is certainly something we can raise, but I'll pass it back to you for the first half of that question.
Yeah, I think for managed alcohol programs, it's better when it's not clinical because it's so interesting looking at managed alcohol programs. The ones that we run are Well, we run two. One I inherited from the health authority, it's quite medical, and then one that is community-based, where patients self-refer. The intake is not done by a medical person, and that patients choose their own dosing. And I think it's much nicer that way. And I think a lot of managed alcohol programs like Health Canada are quite hidden, where I think about, even within the PHS, we have managed alcohol programs that I don't know about because it's really money management. Well, someone will come down to their project manager of where they live and say, I'm getting my check tomorrow. Would you help me get my check and buy a case of sherry? And can you keep it and give me, a liter of sherry a day? No, what a great idea. Like, what budgeting for the month, you know what I mean? It's the same way that I like budget going out to dinner, or like, and so really it's like financial planning and a community intervention. And so I think in these hotels where there's no clinical staff, it's very appropriate to have alcohol delivery to people, because managed alcohol is a community intervention, and that people are very good at titrating their own alcohol, and that we know over time they actually drink less when their alcohol supply is secure. Because I think it's so stressful to be an alcohol user with seizure, in that you're always drinking to avoid seizure. And it's incredibly stressful. So when you get alcohol, you want to get it in you, especially if you're homeless, because you're worried someone's going to steal it. And so then when you get someone on a daily allotment that they choose, over time, they're like, oh, God, okay, you can rest. It's almost like your brain can let go of that anxiety and that sort of survival drive. And then so people naturally drink less over time on managed alcohol programs. And so for funding, we have had lots of private donations that we're spending at PHS, and then like in our operational budget. So funding is always the challenge. But in our managed alcohol community program, you brew it, and then we have the drinkers who come to the program participate in the brewing. So that's been quite a cost savings for us.
So yeah, this ties into another question, or question from Kathleen, that she's asking, do the clients pay for the tobacco and alcohol, or does the program? So I guess what you're saying is it's kind of both.
Yeah, so for COVID, we are securing funding to buy alcohol, and then our health authority has bought alcohol as well, because we saw that was a need to have for isolation, to protect the community. But baseline, the participants pay, but it's in like a subsidized way where we partner with breweries to brew our own.
Perfect. A question from another attendee: Can the prescription of alternatives be accessed outside of the Lower Mainland? And what is the best way for our peeps who meet the eligibility requirements to go about this, particularly if they don't have a healthcare provider?
Yeah, so I mean, that's different community to community. So we have in the guideline document online where people can phone the Rapid Access Addiction Clinic in Vancouver or Victoria for intakes. We always encourage, this is a BC-wide document. So wherever you are, you can go to a clinician, a nurse practitioner, or physician and request this. And it's always best if it happens with your own care provider. And then you can even have that person bring the document in with them. And then that care provider can call the physician advice line and speak to a clinician just to say like, yes, this is reasonable, it's okay. I know it seems a bit crazy, but this is okay for you to be prescribing right now in this context. So it really varies community by community. I mean, family doctors and nurse practitioners are on shortage anyway, so it's hard for people who are totally unattached to care.
The question here from Pamela is asking about how to get safer drugs now shareable. But you've referenced a number of documents in here, including the PHS policies. Will you be able to share those with us? And we can
I mean,
post them?
The document that this presentation is based on is up online. It's anyone can just Google it. It's a BCCSU, I think, risk mitigation prescribing document.
And the policies and whatnot that you have, and the shareables, is that all contained in there, or would this be separate?
No, because it's just the BCCSU documents that are. So the other documents in this presentation, like the OAT prescribing changes for BC, we created like a memo for all OAT prescribers. That's all available on the BCCSU website.
Okay. Quinn's asking, what advice can we give to non-clinical staff supporting and advocating for people with active harm reduction plans?
I guess you want your ducks in a row, because I'm working on this sort of very question at the PHS to how can I help our housing staff help the clinicians start people on safe supply. And so it's nice to come to help support that relationship between our clients and the clinicians. We're lucky at PHS that we have very positive relationships, but in different communities, you might not have such a positive relationship with your prescriber. So it's nice just to approach it you know, I always tell my patients when they're going to see a specialist, like if they want to get like a hip replacement or something, and we're worried that it's not going to go ahead because the, you know, the ortho is going to say no or whatever. I say, like, turn your charm up to 11. Like, wear your best outfit. Like, show up there. Like, let that orthopedic surgeon know you're going to do all your rehab exercises. That like things are going to go really well. Like, you just need to charm them. And so I sort of prep my patients sometimes to go see consultants, and they're like, oh yeah, doc, I got this. It's okay. Like, because you really want them to be able to get the intervention that they deserve. So I'd say as an outreach worker, in BC anyway, you want to know what coverage and MSP the person has, like if they have a PHN, and have that information gathered, maybe along with their ID is very helpful if they have ID. If they don't, then that's okay too. And then you want to know like details about like who's the last doctor they saw, what medications are they on right now. So you can sit with that person and sort of like make a little plan to go to the doctor, and then to make a little plan to say like, okay, how many overdoses have you had in the past 6 months? How much are you using every day? And often patients will say like, as much as I can get, or like they'll be quite vague. But I find money is a really good way to get that history, to say how much money are you spending? And sometimes they'll say like, oh, you know, $600 on check day and $0 on other days. And then you're like, oh, okay. So that gives me a little bit of parameters for knowing about your drug use patterns and how to dose you, actually. It's all still guesswork a lot of the time, but it does help you whether you're doing it at the top end or the bottom end. So like sometimes patients will be like, oh, as much as I can get. And I'll be like, well, does that mean an 8-ball or does that mean a paper? Like, what is as much as you can get, you know? So it's nice to sort of maybe sit down with the person and map out a plan for the things that you want to bring up when you go and see the prescriber. And then I would say as well, be gentle with the prescriber, because I think that the community of practice in BC, like we are nervous, I think, as physicians about rolling this out, because this is totally new. And so just be kind to us as we work this out. And that a lot of the times, I've been cautioning patients, you probably won't get a same day start because you have to make sure your plan G is in place. I want to, like, if you have another physician or ER notes that I want to get, like I have to get a bit of collateral, do a bit of discussion in order to start you. We want to make sure your coverage is in place. I want to do your urine test. Like, you know, there's a lot of things that we want in place. So I've told people 24 to 48 hours for the start. So it's nice to prepare the person when you're going to see a prescriber to say like, we might not get what we want today, but like, let's start the process. And then maybe you're going to start them on doses that they feel are much too low. And you can say like, oh, okay, like, can we call you tomorrow and let you know how I feel? Like, can we adjust this over time? What's the ongoing plan and how can we tinker?
Robbie in Ontario was asking that they have a client on treatment daily. The client relapsed to street drugs and is missing clinic appointments. Do you have any material to assist with coaching through relapse?
Oh yeah, I mean, I feel like all my patients are just relapsing all the time. You know, I think relapse depends on if your goal is to not use drugs. Like that, for many of my patients, that's not their goal, and then that's okay too. So for coaching through relapse, like I guess I just tell people like, don't feel embarrassed to talk with me about things. Like I always want to talk with you. No one's embarrassed about high blood pressure, and so you know you wouldn't come into the office and if your blood pressure was high, I wouldn't shame you and you wouldn't feel embarrassed. We would just talk about adjusting your Ramipril. So it's the same with drug use. If your goal is to not use drugs and then you use drugs, like let's just talk about it. I found that for when I worked at inpatient, it was detox then we called it, but now withdrawal management, that a lot of times patients would say, oh, they wouldn't take any of the medications we were offering them. And they said, I want this to be a very unpleasant experience. So I remember that so I don't relapse. And I'd always say like, oh, I want the opposite. Like I want you to have a really nice time here so that you come back if you do relapse. Like we don't want this to be unpleasant. Like you've been through so much, like just take this Gravol, please. Like, you know, there's no need for you to be throwing up while you're here. I want you to be comfortable. So I think that with relapse, it's important to tell people like, you're not back to zero. There's that sort of fuck it phenomenon that people will have. Well, if they use like even a little bit, like let's say they have a kombucha and they were in recovery from alcohol, and they're like, oh my God, you know, like fuck it. And they just start drinking again, to say like, oh, you know, like a little bit like that is just a blip. I say like, oh, you know, we'll write it off. Like doesn't even count. You're doing great with your health. And then it's also important to put it in perspective. Like if someone's smoking $10 a crack once a month, and they're beating themselves up over it, but their heart is healthy, their blood pressure is fine, like they're young, I'm like, oh, well, you know, how is this affecting your function and how is this affecting your life? Like you're still working, you're still housed, you've got a nice girlfriend, you're happy. That like, don't be beating yourself up over something that actually is not impairing your function.
Awesome. Do you have any suggestions on how we can support clients in accessing this when they have a primary healthcare provider who doesn't have an understanding of harm reduction or prescribing medication for substance use?
So I guess like there's a whole array of prescribers, and it depends on the relationship that you have with that person. But that people, any prescriber in BC can prescribe this now. So I would just start and bring the guideline into them and say like, I'm interested in accessing this because I am really worried about my COVID risk. And then when we frame this as that we are in a pandemic, I am certainly practicing social distancing. Like I've not left my house a lot these past few weeks. That you know, if you're someone who uses drugs and you say like, my goal is my own safety. Like, I don't want to be leaving my house. I don't want to be going to my drug dealer. I am worried. Can you help me with that? That's a really nice way to frame it. And then to say like, there are guidelines now that say that it's okay for prescribers to prescribe this way. And they're signed off by the Ministry of Health and our colleges. So our regulators have said, this is okay for you to prescribe. And then that's your first point. And then, you know, see how you go. And you can let the prescriber know there's a line they can call to talk to a physician to support them. And then if that goes very sideways, you could like contact on the forum if you're here in BC to get connected to the Rapid Access Addiction Medicine Clinic. Yeah. But I would try your own prescriber first because that's better for your long-term care. Because like, let's say 6 months or a year from now and COVID's all done, like, thank goodness, I can't wait. You know, you want to still be with that person who you have a longitudinal relationship with to be like, oh, okay, what's now my plan for this Dilaudid? What's my plan for this Ativan? Where are we going?
Have you heard whether or not these the BC guidelines are going to be adopted by other provinces, or this is going to go across the country?
I don't know. We just published them like a couple of days ago, so we're still figuring it out.
Come on, you haven't got the rest of the country organized yet.
I hope so. But I think even for other provinces, like for physicians, like often it's sort of silly that we have provincial guidelines. Like we have provincial guidelines for opiate agonist treatment, and then we have our national guideline as well. But like, really, do we need specific provincial guidelines for all these things? Like, no, probably not. And that if I were to do something that is standard of care in Ontario, I would feel quite comfortable if every doctor in Ontario was prescribing this way. If I was here in BC, I would feel comfortable taking on that prescribing practice.
How do you recommend safe needle exchange programs continue their service when physical locations are closed as a result of COVID-19?
Oh yeah, I mean, that's a big challenge. We have not closed our locations, but we've just instituted social distancing in our locations. So like injection booths are further apart. And then for our harm reduction dispensing, like usually we would have like sort of a buffet that you could go and like you get your little bag and like pick all your different things that you wanted, but we've changed it so we're creating little packets of harm reduction supplies that you just pick up so that there's not close interaction and you're only touching the things that you're taking.
Terrific. How can we support harm reduction practices in isolation shelters? If a community has a consumption site, the individual will need to leave isolation, potentially contributing to the spread of COVID-19. Are there things we can do on site to support individuals at an isolation shelter, or should we be thinking about safe transportation?
Yeah, I mean, it's all context specific, I think, for what that transportation would look like. But if someone is COVID positive, like not just in isolation, but confirmed positive, like you really just want them to stay at home. You don't want them at your overdose prevention site. And hopefully this prescribing will, like the goal is to decrease their overdose risk because they're using a known substance in a known amount, and that we had no overdoses in our IOT and TIOT programs. So even for my injectable opiate agonist treatment program now, I'm giving take-home doses for people to use alone in their rooms and feeling confident. Like you've been on 170 milligrams of hydromorphone IV twice a day for a year. You can use 150 milligrams of IV hydromorphone alone, like that you've never even had sedation post-dose. And so I feel very comfortable for you to use that by yourself without anyone else there, because that's just your baseline dose. So we've tried, we're still kicking this around at the PHS to figure out what we're going to do about like by distance observation, so that you would like let one of the workers know that you're going to inject, and then maybe they knock on your door in 10 minutes to make sure you're still awake. But then it's a whole thing for safety for your workers where they need proper personal protective equipment. And then you can't do ambu bags or oxygen because they're aerosol generating unless you have N95 masks. So right now we're just doing Narcan and 911.
Okay. Question on isolation shelter again. If we have someone in an isolation shelter, how can we tell withdrawal symptoms from worsening COVID symptoms?
Oh my gosh, yeah, totally. That's a really good question. And I think that that comes up a lot in clinical care, because patients will come in and be like, I'm dope sick. And I'll be like, oh, what do you think you're dope sick? And they'll be like, they're on 150 methadone. They've been on that for 10 years. And then suddenly they come in dope sick. And no, they weren't dope sick, they had the flu. And so I think, sweats, malaise, aches and pains, headache, are the same for the flu and for opiate withdrawal. And then for alcohol withdrawal, and that I think a lot of times for people when they have many years of drug use, that they are not that in tune with how their body is feeling. And often their brain will misinterpret physical symptoms as withdrawal, because any discomfort was alleviated by drugs in the past. So it only makes sense. And then, so I've had lots of times where someone will be like, getting stable on opiate agonist treatment, and they'll be like, my knee hurts. I'll be like, oh God, how long's that been going on? They're like, oh, I don't know. I just noticed it. And then we'll do an x-ray and it's bone on bone. They have a horrific osteoarthritis that's probably been there for 20 years and then just never noticed it before. And so I think it's a lot of balance for people getting used to what their body feels like. And so oftentimes with people, when they get a physical illness and they're opiate users, I talk with them about that. And I say, think about these symptoms, and then think about that it's not opioids that's causing it. Don't go out and use opiates to try to ameliorate these symptoms, because opiates are not going to make this better. You've got pneumonia. And so I think it's just a nice chat with each of those people. And that if they are on a good amount of opioids, and if it's even easier if they've been on it for a long time, and then they're coming to you and saying, oh, I'm dope sick now, but I wasn't before, then that leads you to say oh, this is probably some other underlying cause.
Okay. Do you have any resources to share on ways to increase safety or reduce harm for folks who are trying new drugs during this time, for isolation sites where people can't access their regular supply? I am perhaps incorrectly, the writer is saying, assuming that folks might try new drugs or get them from new sources.
Oh, I think that's a really good thing to think about, because as the drug market changes, people will have to change who they buy their drugs from. And then as well as people are moving. So if you're in an isolation shelter where before you were homeless on such and such a corner, your drug dealer is not going to be delivering to your isolation shelter. And so it's always a risk. I always worry about my patients when they're traveling, that if you're, you roll up to a new town and you're like, okay, where do people have fentanyl here? My gosh, your risk of death is high. And so I think that that's really important. We have done, or we're trying anyway. It's, every time we announce something, we're like, oh, but it might change in an hour, or where it's also fluid. So don't hold me to what I say here, because maybe it's a change in an hour. Okay. But we've been trying to talk with patients about these risks, and about that we don't have oxygen and bag mask ventilation anymore, so that we really want you to do a test dose. Do the titchiest little test dose. I tell people, take a lick of it, rub it on your back, take the teeniest, tiniest amount you can imagine, just so that you know that you're safe. And that especially if they're somewhere that is safe, because I think for often people will smash their whole use or their whole amount when they're outside. Especially women, because you're worried about being assaulted and you're worried about those drugs being stolen, but you're safe here. So why not just use a titchy little amount? And then in 10 minutes, use another titchy little amount and a little titchy amount, and then you can feel safe, and then use half, and then use 75%, that you have the luxury of titrating this maybe over half an hour, because you're in your space. No one is going to steal this from you. You're safe here.
So we have one more question in the Q&A panel, and a bit more time. If there's other questions people have, please submit them. But this last question is, are there separate considerations when working with youth, or would the guidelines be similar?
Oh yeah, well, we put in youth that you can apply these guidelines to youth, but youth are always a totally separate category. I bow down to any clinician who treats youth, because I think that it's its own very unique set of circumstances that I actually don't deal with very much in my clinical practice. The challenge with youth is that often they don't meet the criteria for substance use disorder, but they meet risk of death. So a youth might be using once a month and not have a physical dependence on opioids, but be overdosing on fentanyl once a month. Or they're using, and they're not intending to use opioids, but they're having overdoses because it's contaminated their crystal meth. So always the question is, do I provide youth with Suboxone or methadone and give them a physical dependence on an opioid to protect them from overdose when they weren't physically dependent before? And I think that's a question every time, and every time the risks and benefits and weighing those choices is very unique because it depends on each individual circumstance. So I would absolutely phone someone who is a youth expert in addiction medicine to chat through the case. I would talk with that youth, whoever is their support, like where they're living, their family, if that's appropriate, and then make an individual plan for that person. So youth are not excluded from this, but youth are a special consideration, that's for sure.
Terrific. Well, thank you very much, Dr. Sutherland. I see that as the last of the questions. Thank you very, very much for this presentation. Brilliant, super, super helpful. I wish we could clone you and sprinkle you all over the country and help out a lot of folks that are struggling to figure out how to do this work in light of COVID-19. But thank you very much for this and your life-saving work in Vancouver. Thank you as well to everybody on the line. I know that this is a very challenging time for everyone. I want to thank you for the work that you're doing, the risks that you're taking on behalf of Canadians and folks that are experiencing homelessness and substance users in this country. Thank you very much. This recording will be posted on the CNH3 website. It's cnh3.ca/resources. Just so you have it. It'll also be emailed around. We'll email a link to the recording and the presentation around this afternoon, as soon as the recording is ready. And we'll also make sure to share Dr. Sutherland's presentation. All the material will be on the CNH3 website as well. And last but not least, just want to let you know, the Canadian Alliance to End Homelessness is working hard and working with CNH3 to support your work and your response to COVID-19. Please stay in touch with us. Let us know of your questions and concerns so that we can help, provide the materials that you need. We can advocate for the resources your communities need, and we can help you do some of this problem solving so that we keep our homeless neighbors safe and during this time. So thank you all very